I dig, today not today, and when I finish, you go no say na me, as you did the delay, to prove my loving, you must chop my money, cause my bank alerts na bagam, my checking on the bounce, my mansion on a badam, baby take a look around, my bank alerts na bagam, my checking on the bounce, my mansion on a badam, make you take a look around, girl, it's up to you, but I dey pray you say I do, go tell your papa, say na me they come for you. Yo go go, Agent and get bishop on a egadigo. Yo go go, Agent and get bishop on a ifadigo. Like play, the person we want your few run, they beg to stay. Them say I the grace, say which can love be this? They don't know how I feel. Baby say something, make we do something. Yeah, let me hear you say I do. Baby say something, make we do something. Yeah, baby muna gige bio, cause my bank alerts na bagam, my checking on the bounce, my mansion on a badam. Baby take a look around, my bank alerts na bagam, my checking on the bounce, my mansion on a badam. Make you take a look around. Girl, it's up to you.
And it is truly with a great pleasure and deep sense of honor that I welcome all of you to this Pharmaceutical Society of Nigeria Board of Fidu's public lecture and media review meeting. Today's public lecture is on the topic Insurance-Based Healthcare Financing, Key to Achieving Universal Health Coverage in Nigeria. And truly this topic is very, very germane to our contemporary times, when our health indicators are not pointing in the right direction, when the financing of our healthcare delivery services is truly a major bone in the neck of healthcare delivery in Nigeria. Now, I want to assure us that the eminently qualified personality has been brought in to handle this very important topic today. And at the end of this public presentation, we expect that the Board of Fellows will come up with practical steps that we are going to follow in order to ensure that we distill out some real concrete action plans that is going to help to address the issue of public health financing, which has been a major impediment to universal health coverage in our country.
It's my singular privilege and honor so to do. As we all know, we are gathered today for the 8th public lecture of the Board of Fellows of the Pharmaceutical Society of Nigeria as part of our 2026 mid-year meeting. The theme of this year's conference, which is Insurance-Based Healthcare Financing, Key to Achieving Universal Health Coverage in Nigeria, which will be delivered by no other person but the Director General of the Health Insurance Authority, Dr. Kelechi Ohiri, ably represented by the Director, Lagos, NHIA, Pharmacist Femi Adeoye. You're welcome, sir. After 21 years of launch of the National Health Insurance Scheme, Nigeria is yet to achieve 10% of the universal health coverage. And the big question is, why is this so? At this forum, we will not only be educated by the team of experts invited to speak on this theme, but we hope to identify key actionable points that will improve the implementation of the scheme. I therefore use this opportunity to appreciate all the speakers, the keynote address speaker, Dr. Kelechi Ohiri, Dr. John Iwu-Ajoku, the MD CEO of Hygia Group, and Professor Lere Bale, the President of the Nigeria Academy of Pharmacy. Thank you all for accepting.
If you bought a car today, you will take an insurance. Why? If I have to go with that car, you have to get it fixed. You buy a property, you take an insurance. You buy gold jewelry, you take an insurance. You buy a good watch, you take an insurance. You have goods in transit, you take an insurance. You take an insurance for your life. So when you are dead, your members can get something because you are dead. It's an insurance as well. Why then? That's my imagining things. I can't imagine what happened to us. Why we don't insure our health? We insure our death. When you're dead, but you don't insure our lives. And I think that made us look at this theme for this year. And I am excited at all the people who are here, just as who are here. I want to understand after this meeting what happened to us. Want to imagine what happened to our thoughts that till today we don't insure our health. When you're sick, you must go to the hospital to pay your bills. Many of us are people that are aging. At a point, you don't have the resources to take care of yourself. How do you continue to live in good health like our prince, who at 83, 84, 85 is still looking like he's still 65? You need to take care of your health. Next to us here, we have one of the biggest hospitals here in Lagos. On TV every day, they're talking about what they do for us. The question is, can we go to hospital and access health? Answer might be no, because we can't pay out of our pockets. But after the discussion today, we will all access health at the best places because we'll be told how to access the health. The annual lecture series of the BOF has become an important platform for thoughtful engagement on issues of national importance, with a view to offering immediate and long-term solutions and direction. This year's theme, insurance-based healthcare financing, the key to achieving universal health coverage, is not only timely and significant, but also fundamental to our nation's health and socio-economic development. It challenges us to examine how Nigeria can build a healthcare system that guarantees equitable access to quality healthcare for every citizen, irrespective of income, social status, and geographical location. Are you in the rural area? Are you in town? In Abuja, Lagos? History reminds us that every great transformation begins with courageous conversations followed by decisive action. I believe that Nigeria possesses the knowledge and expertise and human capacity to achieve universal health coverage. What is required is our collective resolve and determination to translate vision into reality. So today, we'll go to that conversation that will make us take actions towards achieving universal health coverage.
I want to assume that we pharmacists in this hall, all of us have something in common, and that is that we are married to pharmacy. Not by force, but because we love pharmacy. We've gone through years of rigorous academic training, and at the end, we get married to that profession. And we find that when we marry that profession, there are some pimples on the face. And we look at other faces, but it's important to stick to your marriage to pharmacy, to take care of pharmacy, especially in times of difficulty. And that's what we are all charged to do. Philosophers tell us that a happy man marries the girl he loves, but a happier man loves the girl he marries. A happy pharmacist loves the profession of pharmacy he has married, and a happier pharmacist continues to love pharmacy despite all the challenges. May your happiness continue to flow. And today, the subject you have selected excites me. I look forward to learning and maybe unlearning from the fresh facts. Some people can say, why insurance, health insurance? And I say, why not? True, it's an old subject. As far back as 1883, the German Chancellor Otto von Bismarck had promulgated an act which he called the Sickness Insurance Act, directed as helping employees that were under the level of payment for convenience, just to assist them. And it was a roaring success throughout Germany in 1833. To think that it's not until 1999 that we had a decree, NHIS. Goes to show you Africa vis-a-vis the northern hemisphere in all professional attempts. And it was not until 2005 that it was launched. That's 21 years ago.
We pharmacists, we're proud of pharmacy. We members of the glorious PSN, Pharmaceutical Society of Nigeria. As men of honor, we join hands for pharmacy, drug making, dispensing, drug retailing, wholesaling, politics. We are there.
My colleagues, I'm happy to identify with the Board of Fellows about the topic they have chosen today for our media meeting. Health insurance is a very important aspect of life, not even health, life. Because if our health insurance is working, many people will not be spending their hand-earned money in treating diseases. And for those of us who are fellows, I don't want to believe there's any fellow that is less than 50. And when you are 50 and above, you catch all these chronic diseases. You can't avoid them. And that's when you need health insurance. So we should please pay attention to the keynote address. So I will pick salient points in the lecture so we shall implement. So on behalf of the NEC of Pharmaceutical Society of Nigeria, I congratulate the Board of Fellows on this occasion of the public lecture, and I wish them success in the media meeting. Thank you very much.
Universal health coverage, UHC, is not simply about increasing the number of health facilities or healthcare workers. It's about ensuring that individuals receive the right healthcare services without suffering financial hardship. This principle aligns directly with Sustainable Development Goal 3, which calls for healthy lives and well-being for all, including universal access to quality essential healthcare services and financial risk protection. Nigeria's journey toward UHC evolved through the decades of reforms, including the establishment of the then National Health Insurance Scheme, NHIS, as a major step toward transition from predominantly out-of-pocket healthcare financing to a structured risk pooling system. However, Significant challenges remain. High out-of-pocket expenditure continues to place financial pressure on many households, particularly vulnerable populations. Therefore, the challenge is therefore not whether health insurance is necessary, but how we can strengthen and expand insurance-based healthcare financing to achieve meaningful coverage for all Nigerians. Insurance-based healthcare financing provides a sustainable mechanism where resources are pooled, risks are shared, and access to healthcare based on need rather than ability to pay. A strong health insurance system provides financial protection, most quality and accountability among providers, strengthens preventive and primary health care, and improves efficiency of the use of health resources. For Nigeria, health insurance must therefore be viewed not only as a payment mechanism, but a strategic instrument for health system transformation. The National Health Insurance Authority recognizes that achieving universal health coverage requires an inclusive, responsive, transparent, and sustainable health insurance ecosystem capable of reaching all Nigerians, particularly the vulnerable and the underserved population. And these people are the ones who are usually missed out in most systems. The federal government's commitment to transforming Nigeria's health sector is clearly demonstrated through the renewed hope agenda of His Excellency President Bola Ahmed Tinubu, GCFR. At the core of this agenda is the recognition that healthy population is fundamental to national productivity, economic growth, and sustainable development. The health priorities of the renewed hope agenda provide a roadmap for strengthening Nigeria's health system with emphasis on improving equity and quality of healthcare services, strengthening health financing and national insurance, expanding primary health care, promoting preventive care, and building a more resilient health system. NHI's mandate strongly aligned with these priorities. Our focus at the NHI is not only on expanding enrollment, but ensuring meaningful coverage where Nigerians can access affordable, timely, and qualitative healthcare services whenever they need them. This vision aligns with the Health Sector Renewal Investment Initiative under the leadership of the Honorable Coordinating Minister of Health and Social Welfare, Professor Muhammad Ali Pate. The initiative provides a comprehensive framework for revitalizing Nigeria's health system through improvements in governance, health financing, service delivery, infrastructure, human resources, and health outcomes. A renewed health system requires a renewed financing architecture. Insurance-based financing provides the platform which investments in healthcare can translate into improved service delivery, stronger accountability, and better outcomes. It's true that there are several other financing models, but that which is sustainable and that which is preferred globally is health insurance. This more or less leaves us with no choice but to find ways to move all Nigerians towards achieving universal health coverage and making sure that all Nigerians have one form of health insurance or the other. That is obviously the only way we can escape catastrophic health expenditures, which stares us in the face. I am sure that we have all heard that every Nigerian or every person is about one sickness away from poverty. And this is a reality. And this we must protect Nigerians from. By strengthening strategic purchasing, improving provider performance, and ensuring that resources are directed towards population health needs, health insurance can become a major driver of health system transformation.
My president is Estate Surveyor and Valuer Malam Baturi Ali Mohammed. He's unavoidably absent, you know, the normal thing. He's unavoidably absent, and so on and so forth. But he sends his best wishes. And the topic, insurance-based healthcare financing, key to achieving universal healthcare coverage in Nigeria. He agrees that it is very relevant at this time, even as we all know what Nigerians are going through regarding healthcare and the cost of healthcare. My president has also asked me to tell you that he is very willing, not just him, the estate surveyors and valuers, our institution are very willing to partner with you to ensure that universal healthcare is available to everyone. Thank you very much. Happy deliberations.
I will say that while you in that industry work tirelessly to discover, manufacture, dispense life-saving therapies, we at the Chartered Institute of Administration ensure that the structures supporting your science are robust, efficient, and sustainable. Science, as we all know, saves lives, but administration scales through lives saved.
The healthcare delivery of this country, and we, the administrators, have to go hand in hand with you to operate in the lockstep. The industry relies heavily on the administrative pillars through robust supply chain administration, regulatory compliance and governance, navigating the complex health corner policies required, and also ensuring the sustainability of the healthcare business model. We all know that a sound financial and operational administration is what keeps the lights on in these two industry professions. It is said that the finest medicine in the world is useless if the administrative system's delivery failed. I hereby called on the Pharmaceutical Society of Nigeria to collaborate with Chartered Institute of Administration to deepen the partnership between the two institutions.
It is with great pleasure that I convey to you the warm greetings and best wishes of the Council and the entire members of the Nigerian Society of Engineers on this occasion of the 8th public lecture of the Board of Fellows of the Pharmaceutical Society of Nigeria. I especially commend the leadership of the Pharmaceutical Society of Nigeria for sustaining this important lecture series, which has become a respected platform for intellectual discourse, professional engagement, and advancement of ideas that will shape the future of healthcare delivery in our country. The Nigerian Society of Engineers recognizes that the health sector is a critical pillar of national development. Delivering quality, affordable, and accessible healthcare requires the collective expertise of diverse professionals working together to build resilient systems capable of meeting the needs of our growing population. Engineers and pharmacists, alongside other healthcare professionals, have complementary roles in advancing healthcare infrastructure, pharmaceutical manufacturing, medical technologies, research, digital healthcare solutions, and environmental sustainability. Today's lecture provides an invaluable opportunity to exchange knowledge, stimulate policy discussions, and promote innovative solutions
that will strengthen Nigeria's healthcare system. As professionals committed to national development, we must continue to encourage multidisciplinary collaboration in addressing the complex challenges confronting the sector.
I bring warm greetings from the Pharmacy Council of Nigeria. The PCN has always worked with NHIA. One, at the point of accreditation. Two, at point of policy reviews. There is no reform at NHIA that PCN has not been part of. We have always represented the pharmacy profession, the pharmaceutical sector. As we were told by the chairman, policy formulation, policy development, not appropriately supported with policy implementation sometimes give us a lot of challenges. We will continue to work with NHIA at the point of review. Of course, we are not in-house to ensure implementation, but we also have our key stakeholders that we continue to relate with, and be rest assured of our continuous support to ensure that NHIA succeeds. Thank you very much for this opportunity.
Minutes, I will try to take us through the practical steps to achieve universal healthcare coverage. My boss from NHIA has laid the foundation and has spoken glowingly on what they stand for and what they are doing to help facilitate that. I will further try to deepen that. And, you know, in trying to deepen it, it's very important to know where we are so that it will set a foundation for what we need to do and how fast we need to move. So I'll be focusing more on the practical aspect of the implementation, and I'll speak to it, and you will find out that this association is a key part of the execution. You know, it's one thing to come up with policy, and in Nigeria we're very good with policies, but execution becomes a problem. So, and it's also important to be factual with ourselves and know that at the stage we are, government alone cannot do it. There is need for public-private partnership to achieve that. And I'll take you through a couple of those things. Starting point is to even look at where are we at the moment. And when you look at the numbers are quite stark. So if you look at the first indices there, you will see that we first of all measure it based on the global index, which has been created by World Health Organization. And that's a universal healthcare coverage index that shows how countries are faring towards achieving that. Where are we as a country? Where are other African countries? And where is the global number looking like? If you look at the number, Nigeria currently is at 44. The index runs from 0 to 100. Now, when you look at this 44, we are lagging behind when you compare with global index by 24 points. That's quite significant. We may say, yes, it's developed economy, so we expect them to be doing better than us. Well, it's understandably so. But how are we faring when compared with the African average? Remember, we are giants of Africa. But when you compare with global average, we're still lagging behind. The global average is put at 49, and we are 44. And like I said earlier on, globally, the global average is 68. So that's a whole lot for us to catch up with. Not only that is the fact that at the government level, the government have set a priority that 5% of the GDP will be set towards actualizing universal healthcare coverage. But as at 2025, 2026, we are close to 3%. So even from a funding perspective, we are lagging behind. So it means that even the target set by Abuja is lagging behind, and that also creates additional problem for us. The next slide, please, will show us further the challenges which have been spoken about also. That over 70% today in terms of spending on healthcare is out of pocket. And that itself creates a whole lot of challenge for families. So you see, most families today are not able to afford healthcare insurance, either by virtue of the fact that they don't understand how it works, which is also a challenge for us, which is also a knock on those practitioners, those of us driving it, that maybe the awareness level is not that high and the populace don't know clearly how to take advantage of it, and that is costing them a whole lot. So imagine income that is challenged and 70% of it is going to as out-of-pocket expenses. Now, on the mortality rate, while it may have improved over the years, is still quite high. As at last year, we still have over 500 mortality per 100,000 live births. That is quite significant, because when you look at globally, at global stage, most global nations are looking at single digits, but we are still in the hundreds.
Every time there's clinical meeting, a pharmacist stands up to speak about the medication error. So a physician, the most senior physician, maybe a specialist like an oncologist or things like that, will be shivering, because we are discussing medication error that has occurred maybe in the last 1 week, in the last 1 month, in the last 1 quarter. And so with evidence. So an average pharmacist is respected in Ahmadu Bello University Teaching Hospital. And I'm saying this so that you can understand why I speak from position of passion. Every physician will respect a pharmacist when you do your work. When a pharmacist compiles medication error, it's very natural. A physician who is not sure of what he wants to prescribe tomorrow will call the pharmacist first. So what do we need to do in this situation? The public assumes that the pharmacist is there to follow the instruction of the doctor. No. The pharmacist's role was not carved out for the purpose of following. It is for purpose of a second opinion, to confirm that the prescription is correct, to confirm that there's no medication error, to confirm that based on the existing disease condition of the patient, that the doctor have written the right thing. That's the reason why I became a pharmacist. It's not for the purpose of dispensing. It's for the purpose of guaranteeing medication safety for the patient. For you to understand the magnitude of the problem, worldwide medication error is estimated to cost $42 billion. Over 260 million people medication error in places like US. So let's say Nigeria has the same quality of healthcare, and we are 250. It means about 2/3 of 267 million is the number of medication error that exists in Nigeria. And because we do not have that quality of healthcare that they have in US, we should also be thinking something close to 300 million really. And every day a patient dies in US as a result of medication error. So what we can do, either we are in the hospital or in community practice, is to ensure that we are always doing what? We are making compilation of medication error. And we are providing an avenue to ensure that physicians around our community are properly educated. Once we start to do that, we'll be respected not just by the patient, we'll also be respected by the physician. So, my focus today is on why it matters. Nigeria has one of the highest out-of-pocket health expenditure. The preceding person has already spoken about it. The insurance improves financing, does not improve only financing, it also improves access, quality, safety, availability, affordability. The community pharmacies are among the most accessible, the most trusted, the most available healthcare professionals. It's easier to see a pharmacy than to see a physician who runs a clinic. For that reason, we have an advantage. The universal health coverage is not only about access and cost, it must include quality and patient safety. So who is the community pharmacist? He's an health educator, he's a primary health care provider, he's a digital health facilitator, he's a medication safety expert, he's a partner in integrated healthcare delivery, he manages, is a coach when it comes to chronic disease management, is able to participate in facilitation and prevention of healthcare, is a public health advocate, is a medication therapy manager. So why is medication safety so important? And why is community and hospital pharmacies so important? WHO says the unsafe medication practices and errors cost the world about $42 billion annually. 1 in every 30 patients experience medication-related harm. Nearly half of all preventable harm in healthcare is medication-related. That is something that pharmacists can prevent. Up to 1 in every 10 hospital admissions in the developed countries are medication-related. Data, learning, and system improvements save lives and resources. So, we all know that when you have data, if you do not gather data, it means it has not been done. If you document, it means something is going to happen. If you can just gather data at the community pharmacy level and at hospital pharmacy level, the way BU Teaching Hospital does, the respect for pharmacies will not double. It will not quadruple. It will be 10 times. Because no physician will want you to identify that he has made a medication error. So, that's an area that I believe nobody is competing with us. That's an area that we just put pharmacies highly respected. In Ahmadu Bello University Teaching Hospital, an internee can walk into the ward. It's not a negotiable thing. You can walk into the ward, look at the files, identify medication error, and correct the physician.
What are the pray you say I do? Go tell your papa, say na me they come for you. Go go,
We've heard quite a lot about health insurance. And so, but we've not heard from some people. So I want to start from, and I'm not doing this because ladies first, but I want to start from Njide Ndili, the president of the Health Federation of Nigeria. I wonder if everyone here knows what the Health Federation of Nigeria is. Okay. So, Njide, first of all, tell us what HFN is and how you think HFN can play its role in achieving universal health coverage through health insurance.
Okay. Well, good afternoon, everyone. And it's a pleasure to be here. I always feel very comfortable amongst pharmacists. So the Healthcare Federation of Nigeria is, a coalition of private sector associations and organizations and some individuals that want to play a role in supporting government to achieve universal health coverage. I think about a decade ago, the IFC published a report called the Red Book. That was the start of the discussion around private sector and recognizing the role private sector plays in delivering healthcare. In that report, it stated that over 60% of care is delivered by the private sector. Yet, the private sector is not at the table when it comes to policy making. So, across Africa, especially West Africa, there was now the formation of healthcare federations. So in Nigeria, there's a healthcare federation of Nigeria, Ghana, Senegal, all the way across Africa, to become a pressure point, an advocacy body to enable private sector speak with one voice and advocate to government to include us when it comes to policy formulation. So that's really what the Healthcare Federation is about. In Nigeria, we just passed the 10-year mark. So we've been doing this 10 years running now. And I must say that private sector is more and more recognized by the Nigerian government. I must also say a big thank you to them, because now we have the platform, we have a connection, we are actually part of so many committees, and I must say that the Pharmacy Association of Community Pharmacists are actually part of the Healthcare Federation and part of the governing body, to help ensure that the voice of the pharmacists are included in the discussions.
Thank you so much. Thank you. Please, a round of applause for Dr. Abdulkader. We haven't really heard from you, but we have this question about the number of enrollees in private health insurance scheme, right? According to INCAN data, 1.8 million enrollees, of which 1.2 million are in Lagos. What is your characterization of the market, and how can we scale up enrollment? What are the challenges?
Thank you very much. So if we look at the private health insurance market in Nigeria, we see that Lagos actually contributes, the highest. And that is because most of the private sector, the companies, the blue chip companies, most of the companies that are, the largest employers of laborers, most of them are actually located in Lagos. And that's why you have, Lagos having that, high number. But if you compare that to what we have in the formal sector, is actually low. The formal sector, actually takes like over 80% of the population. So even if we enroll everybody in the formal sector, that's private and government, combined together, we only have achieved just barely 20% of the population. So if you look at the market as it is actually a problem created by design. The way the insurance scheme was, conceptualized in Nigeria, it was conceptualized to take care of group. So it wasn't conceptualized to take care of individual. And that's why it's been a bit very difficult, to really, penetrate into the informal sector. Like, if you look at the informal sector, they are a sector that are, their income are challenged. They have, a big volatile cash flow, so they don't have very stable income. And then they believe in a cluster economy. Most of them belong to one group or the other. You have this association, that association, and all that. And then they've also suffered from, trust issues. There have been a lot of schemes, that have been introduced to them, social scheme, cooperative and all that, that a lot of them have been, they've been a victim, of maybe some fraudulent practices and all that. So there is a very big trust gap. So in looking at that market as a whole, so you need to then begin to characterize that market based on, the uniqueness within that market, looking at the set of people that they can pay, but they don't have that money in bulk. So that's one group.
Let's start with that thought.
Okay.
Because your regulator is beside you.
Okay.
So let's go there. So, sir, thank you for coming, for taking. I know you probably had to, thank you for coming. So the question now he's alluded to is that for insurance to work, and this is general knowledge, I mean, we talk about compulsion and we talk about subsidy, right? So there needs to be some level of compulsion, and that's why we are getting only the formal sector, right? But the challenge we are having is that compulsion without subsidy is a cruel joke on the poor, right? Which is what he's alluded to also. So for you as NHIA, first question I'll ask is our health insurance scheme in fact mandatory in practical terms?
Okay. The health insurance is mandatory by law.
By law.
It's mandatory for all Nigerians and legal residents to have one form of health insurance or the other. And so, signed by the president, so it's mandatory to that extent.
That answers my question. Now, why are we having challenges onboarding more than the 8 or maybe 10, or depending on what denominator you use? Why are we having that challenge?
Okay, the first thing I mentioned was that we have already over 22 million Nigerians with one form of health insurance or the other. But if you do a deep dive into the numbers, you'll see that quite a lot of these persons are within the formal sector.
Yes.
80% of Nigerians are within the informal sector.
Yes.
And these are people who may not even have the resources to pay for their premium for health insurance.
Agreed.
They earn money not constant. So there must be a system to bring them on board.
Yes.
Such that they can contribute. I mean, these guys are daily earners, gig workers. Until we have a system that can help them contribute as they earn, so that they can be able to take care of their premium, then we will have a little bit of challenge. Now, your approaches at enforcing the mandatory nature has to be a little bit technical. Number one, you just cannot go to the street and begin to arrest everybody. You have to do some dialogue, build some trust within the system, which is what we are presently doing. Okay. And the trust we are building starts from the persons who are currently enrolled. The question is, what quality of care are we able to give them? Because they, in turn, will become the marketers for the people who are yet to come. So it's easier and better approach to, first of all, build trust, communicate to the people, let them see why they need it, and then they can come. But presently now, we're just still building and trying to win the confidence of Nigerians. Don't forget that traditionally, Nigerians have a little bit of hesitation when it comes to insurance.
Yeah.
We still have to do, that's still a lot of work to be done.
All right, so would you say that over the last 5 years, the trust quotient has increased?
Yes, definitely it has increased. I can say that categorically, because systems are being put in place to make sure that the people who are enrolled get the quality of care they deserve.
All right. Thank you. Back to you, Njide. So he said something that triggered me and might trigger you. He said something about quality of care, right? And you sit with the private sector, right? And there's this talk about capitation and the quantum of it, right? So in terms of the benefit package and the quality of care, vis-a-vis the capitation that's provided, what would you say is the sentiment of your members, in terms of achieving that quality of care?
You're trying to put me on the spot. I think, first of all, it's not really about the amount that is being paid as capitation. It's about the coverage, or the coverage of what can you do with that amount of money, and has it been actuarially determined?
Okay.
What I mean by actuarially determined is, how did we come up with the amount of money
that we decided
that will cover capitation and fee for service. By the way, for those pharmacies who may not know, there's a way to pay for services under health insurance. The first part of it is capitation. That is, you pay a fixed amount of money per member per month under your roster, whether they show up or not. Okay? And these are for primary services, primary healthcare services. Then the other component, which is post-paid after encounter, is fee for service. And these are determined, in fact, by a contract before the patient enters the hospital. And this has to be actuarially determined. I don't know, maybe we can confirm from the regulator when last that was done. Because I know that recently there was an increase, kudos to them, almost 90%. But for more than a decade,
it wasn't.
That rate was fixed, even with all the inflation. So I think this is something that needs to be done, regularly, because the complaint from the private sector, and I don't know about the public sector, is that the amount is not sufficient. But having said that, I think the key thing that we need to look at is really the risk pool. How many people are enrolled? Because I can tell you that if a country of 240 million people, of course the number keeps fluctuating, is enrolled in health insurance and capitation is paid, if all of us were, there will be enough to go around. The funding will be enough because we can't all fall ill at the same time. So it's not about, right now it's not about the money, it's about getting started, getting that risk pool increased, and ensuring that what we define as quality of service, that we're doing the right thing, the protocols followed, the right medication given, and there is a way to actually check for the outcomes and kind of services being provided. I think that's really the core of it. So there's still a lot of work to be done, but I must compliment NHIA because this is the first time in many years.
Yes, that's true.
That the capitation and fee for service has been reviewed.
Yeah. I want to come to Prof. Thank you, sir, for so, Prof, you said some very, very, very daring things during your presentation, right? One of which was that pharmacists can be the first point of call for care. And we all heard him say it, right? Pharmacists can be the first point of call for care, which is the PPP or the primary, and there's a scarcity of workers anyway. So my question is this. We have, pharmacy to population ratio is very low, right? How would this work in effect? And that's what I've been dying to ask you. How would it work in effect? And I want to look for trouble a bit. If I don't look for trouble, what am I doing? Is there any room for patent medicine vendors in this model?
All right. Thank you so much for your question. We have about 6,000 community pharmacists, which is essentially too low to take care of 240 million people. But the regulatory body, the PCN, they have already initiated a process of up and spoke, which has been in the works, that we enable there are two categories of patent medicine dealers. The unregistered one. They are performing legality. But the registered patent medicine dealers will be linked with the community pharmacists like in up and spoke. So that the community pharmacy can have some level of supervisory role and a mini ethical supervision role over the patent medicine stores around the community pharmacy. If we take advantage of that, then we'll be able to reach larger number of people. The patent medicine dealers will deal mainly with the OTC, which is within their purview or regulatory allowance for them, and they are allowed. Then the ethical products will certainly be handled by community pharmacists along with OTC. So under that arrangement, the responsibility of the community pharmacist will go beyond the one location or whichever location is running. We also have responsibility for patent medicine dealers around it. So I am a believer that if it is the life of the ultimate patient that is of major concern to us, we are interested in patient care, we will have to accommodate that very aspect.
Prof, can you say it louder for those at the back?
Okay. the natural process.
Please, Prof, to say for the pharmacists at the back. Yes, sir.
The natural process, the natural feeling is an average pharmacist wants to be, they will say, let only pharmacists operate. But we have only 6,000 community pharmacists. We have over 200,000 patent medicine stores. They are already playing some roles. So, under the hub and spoke concept that the regulatory authority, that is the PCN, are already working on, one single pharmacy, we have supervisory role over a number of community pharmacies around it. So we are taking responsibility for the community pharmacies first, as superintendent pharmacists. You are also supervising a number of patent medicine stores under you in such a way that they are able to perform their work. You remember, we are discussing supply chain now. So every medicine going to the patent medicine stores around, we have to be under the regulatory approval of the community pharmacist. Then there's a supervision as well in terms of service that is rendered in patent medicine store. So a community pharmacist eventually becomes a hub, and then the spokes will be the patent medicine store. Number two, the community pharmacist is now able to reach larger audience that ordinarily would have been able to reach. And so it becomes possible, even under the logistics system, to get major wholesalers, distributors, to sell through the pharmacist to the patent medicine stores under you. Under that circumstance, they are no longer competing. They are now complementary. And that works well for everybody. It's in the interest of the patient, it's in the interest of the community pharmacist, and it's in the interest of the service we desire to render. Because to produce one pharmacist takes years, and to have enough pharmacists to take care of 240 million Nigerians will be a very tough thing. That's why this
Thank you so much.
Was thought to.
Thank you, sir.
Mastercraft on the beat.
Every day by day I just dey celebrate, oh. Everything I do we just dey penetrate, oh. I just want to say oh thank you Jehovah, oh. See I'm living large, I get angels so for my ghetto. Never forget where I come from, not from ghetto. Oh no 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 no. I just want to say oh thank you Jehovah, oh. Ure keneri wo to go Father Father, Father Father, Adekwamu loya no Father Father, Father Father, Ema puti rogu wane bele belo. I call look if I follow one day you must go. See I come from East the enter street, brother you know. Ejinife I turn to beast, you already know. Ima no now yellow mundo ngefe yefe. Oh now yellow me gonge to ya o. Ima nandra po balungu tungeze heze. Asahu balungu tunga koya o. I came so and the conquer. All of them just a wonder. So wish kamu banye under. I fire them with the thunder. Mwana kuzi kwanu nuju. No, mano chill. I cover myself. Makachine kene mego kwango benye zake.
Every day by day, I just they celebrate. Oh. Everything I do, we just they penetrate. Oh. I just want to say, oh, thank you, Jehovah. Oh. See, I'm living large, I get angels so for my ghetto. Never forget where I come from, not from ghetto. Oh no 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 no. I just want to say, oh, thank you, Jehovah. Ure keneri wo tu go Father, 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 Adekwamu no ya no Father, Father.